We're focusing today on something pretty specific, but incredibly high risk, managing Legionella pneumonia when it occurs during pregnancy. The aim here is really practical. We want to give you, the provider, the core actionable information from the latest clinical thinking, diagnosis, treatment choices, the dosing details, and the absolute safety lines you can't cross.
You're looking at potential maternal respiratory failure, septic shock, and a real danger of preterm delivery. Getting the therapy right and getting it right fast is absolutely essential.
Okay, let's dive right into the clinical side. What specific signs, maybe beyond the usual pneumonia symptoms, should make you think Legionella, especially since it can look like other severe community-acquired cases?
Yeah, you really have to keep a high index of suspicion, the biggest clue. Often it's the patient who just isn't getting better on standard initial antibiotics, like beta-lactams. Their condition might even be worsening. That's a major flag.
So non-response is key.
Definitely. And then look outside the chest. Legionella often brings these extrapulmonary symptoms. Think severe headache, maybe confusion, sometimes significant GI upset like diarrhea. That's quite characteristic.
Right, and I recall there's a lab finding often linked to it, something with electrolytes.
Absolutely. You're thinking of hyponatremia, low sodium levels. It's a classic clue. Legionella can sometimes trigger SIADH, inappropriate antidiuretic hormone secretion, which basically dilutes the blood sodium. If you see low sodium in someone with bad pneumonia, Legionella has to be high on your list.
Okay, so we suspect it. How fast do we need to confirm, and what are the essential tools for nailing that diagnosis quickly?
You need confirmation fast, because treatment, especially empiric treatment, can't wait. The number one tool is the urine antigen test. It's quick, it's non-invasive, and very specific for the most common type, Legionella pneumophila serogroup 1.
But it mainly gets that one serogroup right. How do we cover our bases for others, particularly in a pregnant patient where the risk is higher?
Good point. That's where PCR testing comes in polymerase chain reaction. You'll want to run PCR, usually on a respiratory sample like sputum or a lavage specimen, alongside the urine test. PCR can pick up different Legionella species and serogroups, giving you broader coverage. Early, accurate identification is the goal.
Makes sense. Let's pivot straight to treatment then. Patient comes in, moderate to severe pneumonia, needs hospitalization. What's the absolute must-have in that initial empiric antibiotic choice?
Your empiric cover must hit Legionella right from the start, no question. And understanding why comes down to the bug itself. It's intracellular. It lives inside our own cells, primarily macrophages.
And that intracellular location is the crux for antibiotic choice, isn't it?
Exactly. Because your standard beta-lactams, the penicillins, the cephalosporins, they don't get inside those cells effectively. So using them alone just won't work against Legionella. You need an antibiotic that penetrates the cell and gets to where the bacteria are hiding.
Okay, so that leads us to the first-line agent specifically for pregnancy. What's the go-to drug? And crucially, why is it considered the safest primary choice here?
Azithromycin. That's the established first-line treatment. It's a macrolide, it gets excellent intracellular concentration, and it works well against Legionella. The critical safety advantage in pregnancy is its pharmacokinetics. Azithromycin has minimal transfer across the placenta, so you're treating the mother effectively while limiting the baby's exposure. That low transfer is a huge safety benefit.
Perfect. Do we get the specific dosing and duration for azithromycin? Providers need those concrete numbers.
Sure. The standard dose is 500 milligrams, once daily. Now, for duration, if it's a mild to moderate case, you're often looking at a short course, maybe 3 to 5 days. But you have to tailor it. If it's severe or the patient is immunocompromised, you'll definitely need longer, often 7 to 10 days to be sure you've cleared it.
Got it. Now, equally important, what not to use. Is there another macrolide we should generally avoid in pregnancy? And which antibiotic class is completely off limits?
Yes, you should generally avoid clarithromycin. Although it's also a macrolide, some data suggests a slightly higher risk of birth defects compared to azithromycin. Since azithromycin is effective and has a better safety profile, it's the clear preference. And the absolute contraindication, that's doxycycline, strictly contraindicated throughout all trimesters of pregnancy.
Okay, strictly contraindicated is strong. Can you detail the specific maternal and fetal risks that make doxycycline a no-go?
The risks are serious. For the fetus, doxycycline can cause permanent discoloration of teeth, especially if given after the first trimester. It can also inhibit bone growth and skeletal development. And for the mother, tetracyclines like doxycycline carry an increased risk of hepatotoxicity liver damage, particularly in pregnant women. Given that we have safer alternatives like azithromycin, the risk-benefit just doesn't justify using doxycycline here.
Understood. So that brings us to the backup plan, the reserve therapies. When would we even start thinking about using a fluoroquinolone, like levofloxacin? And what's the dose?
Levofloxacin is potent against Legionella, no doubt, but its use is strictly reserved. You only consider it for severe, life-threatening infections or cases that are refractory, meaning the patient is failing to improve on azithromycin. It's definitely not first line. If you have to use it, the typical dose is 750 milligrams once daily. Duration is usually somewhere between 5 and 10 days, really depending on how the patient responds and how severe the illness was initially.
Fluoroquinolones in pregnancy always raise safety questions, historically about cartilage. What's the current understanding regarding potential fetal harm with levofloxacin?
Yeah, that's the long-standing concern, based mostly on animal studies showing potential cartilage issues, arthropathy. That's why they've traditionally been avoided if possible.
But what about the human data, when it's been used out of necessity?
That's the key point. The human data we have, often from situations where levofloxacin was genuinely needed for a life-threatening maternal infection, hasn't actually shown definitive evidence of teratogenicity or significant long-term musculoskeletal problems in exposed infants. It doesn't mean there's zero risk, of course, but the consensus now is that if the mother's life is truly at stake from a severe infection not responding to first-line therapy, the benefit of using levofloxacin to save her likely outweighs that theoretical fetal risk. It's a tough calculation.
Okay, let's talk practicalities. Managing severe cases often starts with IV therapy. What tells you it's safe to switch to oral antibiotics?
Right. Initial treatment for anyone sick enough to be hospitalized has to be intravenous. You need those high drug levels immediately. Switching to oral is a milestone. You only do it when the patient shows clear, sustained clinical improvement, things like fever resolving, oxygen needs decreasing, vital signs stabilizing. For milder cases identified early, maybe outpatient, you might start with oral if they're stable.
And this isn't just about antibiotics, is it? Managing Legionella in pregnancy sounds like it needs a whole team. Who needs to be involved, and what specific fetal monitoring is essential?
Oh, absolutely. This is not a one-person job. You need a coordinated, multidisciplinary team basically from the moment you suspect it. That means infectious disease specialists, high-risk obstetrics or maternal fetal medicine, and critical care. They all need to be looped in early. And for the fetus, especially once you're past about 20 weeks gestation, you need close monitoring. We're watching carefully for any signs of distress or preterm labor, things like frequent non-stress tests, biophysical profiles, and just constant vigilance for contractions or membrane rupture. The systemic stress on the mother can definitely impact the baby.
Then there's the toughest scenario. Severe maternal respiratory failure just isn't responding, despite everything. What's the ultimate difficult step that might need to be considered?
Yeah, that's the hardest call. If you have refractory respiratory failure, the mother's oxygenation is failing despite maximum ventilation, antibiotics, supportive care, then delivery of the fetus might have to be considered, regardless of gestational age. The rationale there is purely about maternal survival. Relieving the pressure of the gravid uterus can sometimes improve the mother's lung mechanics enough to allow ventilation to be more effective, potentially turning the tide for her. It's a decision focused entirely on improving the mother's chance of survival.
Okay, let's crystallize the key takeaways for practice. What's the absolute bottom line treatment hierarchy?
Simple hierarchy. Azithromycin, 500 milligrams daily, is your clear first-line standard. Safe, effective. Levofloxacin, 750 milligrams daily, is strictly reserved for severe or refractory disease. Doxycycline is absolutely contraindicated, and underpinning all of that, rapid diagnosis using urine antigen and PCR, and immediate multidisciplinary team involvement.
Excellent summary, and maybe just one final thought for you, the listener, to reflect on. When we reach that incredibly difficult point of considering delivery to save the mother, how can we better standardize the thresholds for making that decision? What specific clinical or lab markers might help guide us more objectively in that gray area?